I'm going to give the next talk on proximal humeral fractures, and it's going to focus on complications, how to avoid them, and what to do if you do get a complication. These are my disclosures. I have designed a plate for the proximal humerus as my disclosure. That's in the American Academy website. So these are some of the problems we see with proximal humeral fractures. We hope when these plates came out, the locking plates came out, that they would eliminate the problems that we saw with older plates from proximal humeral fractures. That's obviously not been the case. There's still a significant failure rate with proximal humeral plating, and I'm going to talk about how to try and avoid that if you decide to operate in the patient. And probably the first decision you make when you see someone is, well, does this patient need an operation or not? And that's definitely a gray zone. There's a number of randomized trials that show if you have an older patient, older than 65, with a proximal humeral fracture, and you're really not sure if it needs an operation or not, probably it doesn't need an operation. If you look at those studies, they show not a lot of difference between surgery and no surgery. There's kind of gray zone cases. And I won't go into the details, but you need to have a pretty clear-cut indication, especially for someone over 65 to have an operation. One paper that's really helped us a lot at our institution is this one from Edinburgh, Mike Robinson's group. Looked at over 2,000 patients with proximal humeral fractures that presented to their institution, the Royal Infirmary there. And they found about 10% had non-unions. And could they predict a non-union? Because obviously if you have a patient who's going to develop a non-union, that's probably someone you want to consider fixing. And they looked at two things. They looked at the head shaft angle and looked at the head shaft translation. I'll show you what that means. And they developed a risk system for that. If you look at this patient here, the head shaft angle is about 149 degrees, so no varus. Varus is bad. If the head tilts into varus, your non-union rate goes way up. So you can measure that on an x-ray. And then how much does the shaft and the head overlap? That's the translation. And you can plug that into the equation they have. And our residents now at handover runs actually do this. They measure these angles and then say, okay, this patient's risk of a non-union is X% based on this Edinburgh study. So for this patient where the head's pretty well lined up and there's some opposition between the shaft and the head, the non-union risk is low. So you're not going to operate in this patient because of a concern about non-union. A more severe case, if you look at this one, this head's tilted way off into varus, and there's not that much between the shaft and the head left anymore intact, and so this patient's risk of non-union, according to this scenario, is 67%. You can look up this paper, and it's a fairly simple algorithm to figure out what the non-union rate is. We use this a lot in our institution for deciding if the patient's going to heal or not. Malunion, that's a different story, but non-union alone, which most of us would agree is a bad thing here, is very, very predictable according to this particular equation. So we use this on a regular basis. Ralph Hurdle talked to us about the medial hinge. If you look at these two x-rays, the one on the left-hand side looks more severe. The head is split and dislocated. In actual fact, if you look at that long spike of calcar bone, that's a head fragment that's probably going to survive. It's got a lot of soft tissue attached to it. The other fragment's got the GT attached to it. That'll probably survive. But you want to make sure that if you have this long soft tissue attachment, that medial fragment, that's a good thing for the head, and it's going to survive, and you want to make sure to maintain it if you decide to operate, and this person obviously needs an operation. On the other side, the x-ray doesn't look as dramatic, but that head fragment, which is kind of a head split, has got almost nothing attached to it in the medial side. So that's something which probably is not going to survive as a high rate of ABN, and that's what Ralph Hurdle talked to us about, and that may influence your decision-making for that patient. If you do decide to fix this fracture, how do you maximize success? So how do you minimize complications and maximize success? If there's one slide in the talk, remember, this is probably it. You want a good reduction of the calcar. You want no varus. Don't leave it in varus. You want a calcar screw, and then maybe somehow fix the tuberosity. The first three for sure in every study shows a good reduction, no varus, calcar screw, and then maybe do something with the tuberosity as well. So this is the crux of the matter here if you chose to fix things. I'm going to show a few schematics because it's easy to do it that way. Here's the reduction of this fracture. You can see how we've got a good reduction, especially at the calcar in these fractures, and that's critical in trying to get these reduced in terms of minimizing the potential for mechanical failure of your operation. So get a good reduction, number one. When you have that reduction, make sure you get a calcar screw, and that's defined usually as a screw within the bottom 25% of the head or within 10 millimeters of the calcar. I try and slope it really close right to the calcar, and that's where a plate with a variable angle locking system will help you. If you look at where the plates are placed according to manufacturer's instructions, a significant number of plates will actually not allow you to put a good calcar screw in if you put it at the right height. So be careful about that. And the calcar screw is more important to you than the plate height in terms of getting that screw in the right spot. If you don't have a calcar, well, that's all great if you have a nice calcar. What if you don't have that? If you leave it like this, it tends to tip into varus. and bad things can happen, so you don't want to leave a big gap at the calcar. What are your options in that situation, which is a common technical problem? There's a number of things you can do. You can use a fibula or strut, and Dean Lorich was the person who popularized that. You use some kind of calcium phosphate cement, and the New York group has also talked about that. Allograft femoral head to pack in the defect. You can even add a second medial plate. The downside there, of course, is that you have to do a lot of soft tissue dissection to get that in there, but you have to do something on the medial side. You can't leave that gap there. And this is a cartoon of what you can do for a structural graft immediately. I find by far and away the simplest thing is simply shorten the humerus to a stable position. It may make your x-ray kind of aesthetically unappealing, but if you shorten the shaft, not in the varus, so it's got to be a symmetric shortening, and impact it in the head and get that stability in that fashion, I think that's perfectly acceptable. It's cheap, it's simple, and that's what I do most of the time in these kinds of situations. So don't forget about simply compressing that shaft in the head. You can't do it on just the medial side because you tip it in the varus. It has to be symmetric when you do that. A couple examples. This is a male who's 50 years old. You can see if you look at the Edinburgh formula, really there's no contact between the head and neck. I might leave this in a sling for a week or two and see if it lines up better, and if it didn't, I would probably dig in and fix this in a 50-year-old. And you can see the bone quality here is not the greatest. This is him fixed. You can see we have impacted the shaft somewhat into the head. We've got a good reduction. We've got a calcar screw, and that goes on to heal without complications. So you can see the bit of a step on the medial side, which again is not that appealing on an x-ray, but if it gives you a mechanically stable position of the head, I think that's perfectly acceptable in doing it like that. This is another example, 47-year-old male. There's some comminution there as well. You can see this, again, is one that hasn't got a lot of contact between the head and the neck, and a relatively young individual, probably warrants fixation. Again, if it looked better in a sling a week or two later, as often it does, you might leave this alone, but this didn't. So this patient had an operation to fix this, and you can see here, same thing. We've got a little bit of impaction there. Not a big deal as long as it stays straight and there's no varus in the head, and a good spread of screws up top of the calcar screw, and this goes on to heal. What about tuberosity escape? This is another major complication. You can see that the plate here has been sheeted high specifically because it was a good tuberosity piece, and this person was doing quite well. Everything was great, and they come back at 6 weeks like this. And this is an unmitigated disaster for this patient. I don't have a good solution for the young patient this happens to. I don't know if someone else does, but if this person's 45 or 50, you can take them back, free up the cuff, try and get this piece back where it belongs, suture it into place, put them in an abduction pillow forever, and that's a 50-50 solution in my hands in a young person. Older person, you always have the option of reverse, and I'll talk about that in a minute. But for this, it's really a bad thing to see in the clinic, and the head's, usually sagging down out of joint. So we do everything in our power to avoid this from happening. Well, how do we do that? The problem with most of our plates for 3- and 4-part fixation, this is a slide from Gilles Walsh in France, used without his knowledge or permission. And you can see in his cartoon here how the plate doesn't hold the tuberosities. The plate's on the side, the lesser's in the front, being pulled around the front, the greater's in the back, being pulled up and back, and the plates really don't fix it. So I'm a strong believer in plates with flanges on them. There's a number of companies now who make these kinds of plates. This is an example of use of something like that. This is a 41-year-old male who fracture dislocation of his shoulder. Mountain biking, you see he's got a big tuberosity fragment. You can see it right in the middle. I don't want to lose fixation in that. This is a plate that has a hook-type flange on it superiorly. As I say, there's a number of companies that make this plate now. The most recent one I saw was a company called Bone Bridge, and I have no financial interest in that company, from Switzerland by Christian Gerber, designed a similar plate with flanges. But I think you'll see more of those in the future as a way to capture these fragments that the standard locking plates don't capture, and this captured that GT piece quite nicely. We also add sutures there to it, and it heals and does pretty well. So beware of that greater tuberosity fragment. You might want to consider using some mechanical fixation that if it's a big enough piece. Well, I think it'd be safe to say in this particular case that some of the principles I've just talked about maybe weren't followed accurately. So what do you do for the salvage situation? And part of this talk is about salvaging when bad things happen. And I think I need to talk a little bit about reverse arthroplasty here because it really has revolutionized what we do in the proximal humerus. This is a patient who comes after having an operation in a developing country that didn't work out so well. And this is 6 or 8 weeks out. The head's probably dead. And we have some major issues here. So this is a great indication for reverse to salvage it. A failed fixation converted to a reverse is not quite as good as a primary reverse. You've got to remember that. So a primary reverse is a bit better. If you look at the big population study in the province of Ontario, if you had failed fixation, and then a reverse, your reoperation rate was 4 or 5 times higher than a primary reverse for fracture. That's crude data, but it's 10 million people, so it's probably pretty accurate. Maybe some specialized centers can get better results, but in general, it's a higher complication rate. So you can use this as a salvage, but it's not quite as good as a primary. This is a patient we did do a primary reverse on. She's 78, quite active, but you can see that the head's right off in the axilla. There's probably not much left there in terms of blood supply. She needs something to be done, and she had a reverse done with a very good result. Fix the tuberosities if you possibly can. There's some evidence in the literature to support this. There's a good study, I think this is from Norway, looking at reverse versus plates for patients who clearly need an operation, elderly patients who clearly need an operation. The reverse did better, statistically significantly and clinically relevant difference. And the greater the degree of severity of the fracture, so the type C fractures, lots of pieces, the bigger the difference was. For the simple ones, type A, 1 or 2 pieces, was a difference, but not really that significant. But the type C fractures where the head's really blown up, the reverse was dramatically better than fixation. So there's some literature to support primary reverse for these patients as a way of avoiding the complications of fixation altogether by just going straight to the reverse. So to conclude, I'll say get a good calcar reduction. Don't leave the head in varus. That's always bad. Calcar screw, that's under your control with most plating systems, to get a good one in there. Fix the greater tuberosity. If you're happy with the suture technique, great, but if you're not, consider a plate with flanges on it that helps hold that back down. That may be helpful, certainly biomechanically. There's a number of papers out there that show it's much more effective than suture alone. And use the reverse for primary treatment in selected cases and salvage in other ones. And thank you very much for your attention.